Hello, everybody, and thank you for joining us for today's webinar, Implementation of the Nurturing Program for Families in Substance Abuse Treatment and Recovery. I'd now like to pass it over to Mr. Ken DiSergio.
Thank you, Mariana, and welcome, everybody. My name's Ken DiSergio. I'm with Children and Family Futures and the National Center for Substance Abuse and Child Welfare. We welcome you to today's webinar, the Nurturing Program for Families in Substance Abuse Treatment and Recovery. This webinar is the fourth in a series of webinars on evidence-based practices brought to you by the National Center on Substance Abuse and Child Welfare. We are planning additional webinars in the coming months, hoping to bring you the matrix model and another webinar on motivational interviewing, and we'll probably be planning several others as well that we'll keep you informed of. The National Center for Substance Abuse and Child Welfare is supported by the Substance Abuse and Mental Health Services Administration, Center for Substance Abuse Treatment, and the Administration on Children, Youth, and Families, Children's Bureau, the Office of Child Abuse and Neglect. And we, as having the privilege of operating the National Center, we couldn't do it without the support of both SAMHSA and the Children's Bureau. And I'd like, with that, to turn it over to Elaine Stett, our Federal Project Officer for the National Center on Substance Abuse and Child Welfare from the Children's Bureau. Elaine?
Thanks, Ken. And as Ken said, I would like to welcome everyone on behalf of Sharon Amatetti, who is my counterpart at SAMHSA, and also Catherine Nolan, who is my boss at the Children's Bureau, the Office on Child Abuse and Neglect. We are thrilled that we are able to have Ms. Bogage and Ms. Christmas on as presenters on this very important topic. We know that this is something that is of great interest to the Children's Bureau, and really looking at issues around implementation, fidelity, and understanding how programs work best to serve children and families that are impacted by substance disorders. And we are really looking forward to the discussion through the chat function, as well as your responses to the polling questions that will come up during the webinar. And I really encourage you to engage with the National Center on Substance Abuse and Child Welfare, as they have many resources that are available to you. And so with that, I will turn it back over to Ken. Thanks, Ken.
Thanks, Elaine, and we appreciate you joining us today. It's always a pleasure to have you. Today's agenda is around the implementation of the Nurturing Program for Families in Substance Abuse Treatment and Recovery. And today's webinar, as well as the series of webinars that we have brought you around evidence-based practices, is not intended to train you in less than 90 minutes on how to implement this particular program. But it is intended for jurisdictions, sites, grantees, for those of you that are grantees who have selected this program, who may be implementing it now, or are contemplating implementing the program. So our focus is around the implementation issues on the nurturing program, if you will. And so Terry and Diana are going to talk about their experience in implementing the program. We want to spend some time today talking about and presenting monitoring the fidelity of the nurturing program. We all know that that's a critical component of the implementation of evidence-based practices. And then measuring the impact and outcomes of nurturing program for families in substance abuse treatment. So today's webinar, again, is to focus on the implementation issues and the experiences of these two tremendous presenters and the experience they bring in implementing the nurturing program and what their implementation experience can do to help your implementation experience as you are implementing this program or as you're considering implementing the nurturing program. And so with that, I'd like to just take a few minutes to introduce our speakers. And both Terry and Diana are with the Institute for Health and Recovery out of Cambridge, Massachusetts. And the Institute for Health and Recovery is a partner and provider of the Commonwealth of Massachusetts Regional Partnership Grant Program called the Family Recovery Project, in partnership with the Department of Children and Families and the Bureau of Substance Abuse Services and Advocates for Human Potential. And that program is currently being implemented in Southeast Massachusetts, and they have experience with implementing that regional partnership program in Massachusetts going for 7 years right now. So our first presenter will be Terry Bogage with the Institute for Health and Recovery, and our second presenter, and they're teaming on this one, is Diana Christmas, also with IHR. And Terry is the Director of Family and Children's Services at the Institute for Health and Recovery, a statewide policy program, systems development, training services, and research organization. Diana Christmas, our second presenter today, has extensive experience in the areas of substance use disorders, parenting, HIV, AIDS, and maternal child health. She serves as the Parent-Child Services Coordinator for the Institute for Health and Recovery's Parent and Children's Services component, where she co-facilitates parenting groups for families in substance abuse treatment and recovery, as well as provides local and national trainings on substance use disorders, child development, and parenting issues. And so with that, it's my pleasure to introduce Terry Bogage and Diana Christmas from the Institute for Health and Recovery and turn it over to Terry to begin our presentation. Welcome, Terry, and thank you.
Thank you, Ken. Welcome to everybody. It's great to be here. Good afternoon if I guess you're from the eastern part of the country, and good morning if you're not, if you're from the western part of the country. Want to just say thanks to the Children's Bureau, the National Center for Substance Abuse and Child Welfare, to all of you guys, Ken, Mariana, Elaine, and Nancy, who helped us get set up to do this. We're really excited to get to talk about the nurturing program. We hope to hear from folks, answer questions, and have somewhat of an interactive conversation, although I think that's a little difficult on a webinar. But I wanted to just kind of start off by acknowledging that there has been some confusion about which nurturing program we're talking about. We've done a lot of training on the nurturing program. We're here, and I'm going to give you a picture of the cover in a few minutes, and you'll see the curriculum. But the nurturing program for families in substance abuse treatment and recovery, and you can move on to the next slide, is a trauma-informed curriculum, and it really integrates what we know about substance use, recovery, mental health issues, as well as parenting and child development. Originally, I'm going to talk a little bit about the history and development. Diana's going to get into a lot of the implementation details, but I feel like the background of how this came to be is useful for people to understand. Originally, the curriculum was developed through a Pregnant and Parenting Women and Infants Center for Substance Abuse Prevention demonstration project in the early 90s. And at that time, it was piloted at 2 residential women and children's programs, and what was piloted was based on Dr. Stephen Bavelik's nurturing program for parents of children birth to 5, which at that time was on CSAP's Promising Practices list. Those lists have changed over the years. Now we're part of NREP, but at that time it was chosen by the staff who were here because it was a well-documented curriculum. It was aimed at reducing abuse and neglect, which is what the aim of this demonstration project was, and it did have an evaluation instrument, the Adult Adolescent Parenting Inventory, connected. So we were happy to have that, which I'll talk more about in a little while. We are now on our 3rd edition of the nurturing program, and again, you'll see the cover in a few slides. That was published a couple of years ago and really incorporates learning over the past almost 20 years since we first published it, especially around trauma, mental health, and parenting issues. So that's all been incorporated into this 3rd edition. So we have a couple of different ways we're going to try to clarify and figure out for all of the participants which curriculum, if you're using one, that you're using, and if it's the same one that we're talking about. So if you could go on to the next slide. So as I said, during the demonstration project, the Stephen Bavelik's nurturing program was chosen. It was actually difficult to find a curriculum that really addressed the impacts of substance use, co-occurring disorders, and trauma. Dr. Bavelik's curriculum has excellent core values and guiding principles. It wasn't specifically designed to address the issues specific to parents and families with substance use and co-occurring disorders. And so there are several ways in which our curriculum differs from Dr. Bavelik's curriculum. and one of which is obviously that focus on substance use, co-occurring disorders, and trauma. Also in that we really begin with a focus on the parent and the challenges of parenting when you're also struggling with all of these other issues. A lot of parenting programs, including Savilic, start with the child, and so a big difference in this one is that it starts with the parent. And a big focus in our curriculum is, again, on the parent-child relationship. We'll talk more about that throughout the webinar, but that's a very big focus of ours. So those are a couple of the main differences. The curriculum explores the needs of individuals struggling with substance use disorders in a variety of ways. Each of the topics, and hopefully we'll get into some of the details of this, is explored in the context of being in recovery and parenting. So for example, how do you help your child with self-esteem issues when you need to focus on your own self-esteem issues? So we start with the parents and their self-esteem issues. Or another example is, how do you play with your children or teach your children about play when you really never had the experience of playing yourself? So it really focuses on, each topic focuses on the parent's perspective on that topic, and then it moves on to the child. It talks a lot about helping parents understand how they were parented and that huge impact that has on how they're parenting their children. So we all know that, we can hear, those of us are parents, hear our parents' voices sometimes when we're talking to our children, and that's certainly the case for all parents. So we try to help participants understand those impacts on how they're parenting their kids today. And again, strengthening that parent-child bond so that families can heal together. So if we could go to the next slide, we wanted to ask people, there's a polling opportunity a couple of times throughout the webinar, and we wanted to ask people to try to clarify how many people are actually using the Nurturing Program for Families in Substance Abuse Treatment and Recovery. It would help for us to know who in the call is using this curriculum. So if people could answer that question, and then we'll find out what the results are.
We have 36% of the folks who responded are using the Nurturing Program for Families in Substance Abuse Treatment and Recovery. 54% are not, and 11% are not sure.
Okay. All right. Well, that's helpful. So more than half of you are not using this program, so this is an opportunity to learn about it. And over a third of you are using it, so hopefully if you have specific questions or concerns or issues that have come up, we can try to address some of those. And for the not sure group, hopefully you'll know by the time we're finished. The next question is just, are you using another Nurturing Parent program?
Okay, great. And those results, Terry? Of those who responded, 21% say they are using another Nurturing Parent program, 57% say no, and 21% say they're not sure.
Okay. Well, this is helpful. So we have an idea that there are about a third of you who are using this and over half that are not. And some of you aren't sure, so again, hopefully you'll be sure by the time we're finished. So I'm going to talk a little bit about the relational cultural model because it's really the theoretical underpinning of the model of the curriculum. It was developed at the Stone Center at Wellesley College. Many of you are probably familiar with it. It's important to just mention it briefly because it really underlies the curriculum in every way. And the model really shifts the emphasis from separation, from psychological growth being through separation, individuation, to psychological growth happening through connections. And that's really the basis for growth and development. So the goal of development being to enhance connections with other people and being toward interpersonal connection and interaction. And so you'll see that throughout the curriculum, that's really what we're aiming for: connection, relationship between facilitators and participants, between participants, each other, between parents and their children. So I'm going to move to briefly talking about trauma on the next slide. There's been a lot of focus, which is great, and emphasis in the field on trauma and understanding the very strong correlation between histories of trauma and substance use and co-occurring disorders. We know that this is an old study, actually, from Lisa Najvis, but I still like to use it because I think it's so relevant. Women in community samples report a lifetime history of physical and sexual abuse that ranges from 36 to 51%, while women with substance use problems report a lifetime history ranging from 55 to 99%. So we approach everyone in our group, women and men, with the assumption that there may be a trauma history, kind of the universal precautions approach. We assume that participants have experienced trauma. We treat everyone in a very respectful and trauma-informed way, and I think it's an important statistic and just an understanding that I think most of us have now, that trauma plays such a key role in so many of the participants that we're working with live. So I'll move now to the guiding values of the nurturing program. I think I don't want to read through all of these, but you can read them. The experience of being in the groups, and I think Diana will talk about this when she talks about implementation, is in itself a very nurturing experience. We hope that parents can internalize some of that nurturing and feel and really understand the benefits of taking care of yourself, and then the importance of taking care of yourself first, so that you have the reserves and you have the, your tank is filled up so that you can then better take care of your children. On the next slide, there's a lot of opportunities for having fun within the curriculum. There's a respect for yourself and others in all aspects of your life. We talk about respecting where you live, where you work, where you bring your kids to childcare or daycare, and that we try to just talk about that respect in all of the environments that you may be in. A big piece of one of our guiding values is about recovery happens in families and in relationships, as well as in the individual. Everyone, hopefully by this point, knows that this is a family disease and recovery is a family process. And so one of the guiding values is that this is a process that happens within families. And so doing work around parenting and parents and children together is a very important piece of that. So on the next slide, talks about nurturing the parent and the way that the curriculum does that. There's many ways that the nurturing program nurtures group participants. The curriculum sessions are very structured. Each begins the same, ends the same, has a similar kind of structure so that people can know what to expect each week. There's lots of opportunities to build connections within the curriculum, as I said, between participants and facilitators. We can talk, if there's time, hopefully there will be, to talk about a children's curriculum that we're about to complete that can be used in conjunction with this. And so there's opportunities to build those connections between parents and children. There's lots of opportunities to create that safe place for self-exploration. We talk about the importance, and I'll talk, I think, and Diana more about this later, but of being really helping to build the ability to communicate well with your kids, being honest with your kids, not avoiding conversations. I think this is one of the questions that may have come in about talking to kids about your substance use. And so there are places in the curriculum that really help with how to have those conversations depending on the child's age, their developmental state, but really how to build those connections and have those honest conversations. And again, very participatory. For those of you who are using the curriculum, you know it's very interactive. There's very little didactic facilitator standing up and just talking at the participants. It's very hands-on. And it's lots of fun and creativity. One of the other things I just want to add here is that the approach throughout the curriculum is very non-judgmental. So we are accepting parents as the experts on their children. In fact, we expect that parents come in as the experts on their children. So not only is there a non-judgmental approach, we're looking to parents and saying, you know the best, you know the most about your children, so let's bring that into the equation. There's a quote that we like to use: we teach what we know, but we replicate who we are. This is something that is mentioned in Guiding Values, and I'll talk about it just a little bit here. Many curriculum sessions begin, as I said before, with the parent. So how a particular issue impacts the parent. And then it moves to the impact on the children and the understanding that impact on the children. If hopefully, I'm sorry, we're having a slight technical thing here. Oh, it's fixed. Okay, sorry about that. So we go back to what's familiar when we're parenting our kids, and we know that parents do that too. What we experienced in childhood is what's familiar to most of us. So hopefully that makes sense. Sorry if there was a little bit of background noise there. We had a slight technical moment here, but we're fine. Okay, so if you want to move on to the next slide, briefly, the curriculum is very much designed to be adapted, which is why it says 12 to 17 sessions. Each session is designed to be 90 minutes. We have a variety of adaptations already developed because of different projects we've done over the years. So we have a shorter version, 12-session version. The full curriculum is 17 sessions, but we really work with programs and providers to figure out what it is that would be most useful for their participants, and we can sort of tailor sessions by the needs of the program. As I mentioned before, each session is designed in the same way. Information for the group's facilitator. They always begin with an icebreaker and close with a wrap-up. They also, I think what's very helpful is include additional information on issues or concerns that might come up. So if there's a particular topic, we've anticipated from doing this for so long issues that have come up during those session topics and talk about those in the introduction to that particular session. The curriculum is unfortunately only available in English at this time, but it does really respond to an array of learning styles. There's not a lot of intensive reading or, didactic work, as I said. Multiple intelligences, multiple literacy levels have had, people with multiple intelligences and literacy levels have had success with the curriculum. And it's really quite accessible to a wide range of people. Lots of opportunities to explore culture, both of your own culture as well as the cultures and heritages of other participants in the group through different crafts and sharing and activities on a variety of topics. So in the next slide, I'm not going to read through each topic, but just as a couple of examples, the next two slides list all the topics. We always start with hope. That is quite intentional. A lot of people in early recovery come into our groups, aren't necessarily thrilled to be there. We do say it's a voluntary group, but if you're living in a program where group participation is mandatory, it's not all that voluntary sometimes. So, but it's a session that really does build a sense of hope. We're hopeful that you're in the room. We're hopeful that you're there. Often people leave that session feeling much more positive about being in the group than when they came in.
Sorry, can I just also add that it really sets the tone, because some of the basic things that people assume that someone who's in recovery will totally understand is that hope is kind of like a new transition from moving from active addiction to like what hope really means. They may have had some of that experience when they were younger, but that whole slant and culture of actively using, changing the whole perspective on what words mean and experiences mean. So they're not always really clear. So something that's basic is hope. Everybody knows what hope is, but not necessarily if you're coming from a place where it's been part of your active addiction process to deny hope, to even not believe that hope is existing. That's why you're allowed to continue to stay actively using, because it's hopeless. So we spend quite a lot of time talking about that and really connecting, moving from active thinking to like getting a more positive perspective. And hope is the first one that sets that tone. So it's really important.
Thanks, Diana. And for example, communication I talked about before. We talk about how to talk to your children about those difficult topics, like why you may have had to go away for a while if you were in treatment. You know, again, depending on the age and developmental level of your children, but we really tackle those difficult topics that people haven't talked about, but in a very safe and non-judgmental way. If you go on to the next slide, those are the rest of the topics. Excuse me. And each one, again, really starts with the parent. There's lots of specific, concrete ways to practice. So, for example, managing stress, we practice breathing. We practice, you know, having a very kind of nurturing experience that you can take with you outside of the group. People talk about that a lot as something that's been really helpful for them. In recovery, love, and loss, we, again, very purposefully have that toward the very end, because that's where we really tackle all of the losses that may have occurred due to your experience with substance use. So
I said, before you move on, hi, it's Diana again. Just really wanted, even though I'm going to talk a little bit about it later on, just really wanted to point out the alternative sessions for the fathers that are listed there. Because as we were doing this curriculum and doing the groups, often men gave us a lot of feedback around some of the specific issues that may be going on with them. So we really took some time in working with them and developing some sessions that might lean more closer to the points and perspectives that men might be struggling with, not only due to their recovery and being involved in the criminal system, but just the messages they might have gotten early in life around what it might mean to be a parent, and that some of that really needed to be revisited so they could really feel like they could be involved with their children and that they had something to bring to the table, even though they might not be employed at this time. That the priority really was being involved in their child's life. And actually, how do you do that, given some of the restrictions of what men are going through at this point in time?
Right. Thank you. So on the next slide, I thought we would stop for a minute and ask you all another question. We're used to doing this kind of training in person and having a lot of interaction and discussion, so it's a little bit of a different experience for Diana and I to be doing this on a webinar, but we thought it would be a nice opportunity to just get people's thoughts on this question or this statement. Participants should have some clean time or sobriety before attending parenting groups.
Terry, as you can see, the response categories, 7% of respondents say that they strongly agree with this statement, 45% say that they agree, 3% say that they don't know, 31% say they disagree with the statement, and 14% say that they strongly disagree with that statement.
Interesting. That's quite a broad range.
Yes, it is.
A pretty even split, actually, between agree and disagree.
Hi, it's Diana. And the reason why we even asked this question is given that this whole curriculum really is a partnership between the participant and the staff, and the staff have to buy into it for it to really work the way that it needs to, that we need to also work with staff around getting some clarity and having them work through whatever their issues might be around whether they believe clients are ready, given whatever their treatment process might be, ready to even begin this process. So often, a lot of the work that has to happen is actually working with staff or people who are going to be implementing this to kind of like work through some of their challenges and their barriers, and that happens even before we begin to talk about what their facilitation skills might be. Right. That it's really important to begin to do that, and that the agency buys into, or the leaders of the agency buys into this whole nurturing process, because that's kind of really, you know, what will sustain it over a period of time. So it's really important to kind of like address that, and it can come from any way, and that's fine. that's part of the work that needs to be done.
And, yeah, I'm going to turn it over to Diana in a minute to talk about implementation, but I think that the answers just on our poll are very telling, because that gives an example of what you might walk into when you enter a program. Staff come from a variety of places, and this is a big question for a lot of people. So I think Diana's point is really important, that these conversations should happen beforehand so that you know everyone's on the same page, or at least close enough to the same page that they know what's happening in these groups and can buy into it and really support the participants even outside of the groups.
Because often you can measure whether a program is being implemented, and you can check off, yes, I did this, yes, I did that. But if you're not emotionally kind of tied into it, it's not really going to work, and you're not going to get the outcome that you need to, given the populations that you're working with. So you have to kind of believe in the sense and the concept of nurturing, and believe in terms of this exchange to even begin to really, operate it. Because you can just go through the curriculum, but that doesn't necessarily mean that people have gotten what they need. And that's why this whole idea of, can we go to the next slide, please? That's why this whole idea of when this curriculum was developed is that it be flexible. Yes, it is designed for families and participants that are in treatment, but the reality is that we have expanded it way beyond that to actually work with populations that may have any kind of issues, be it trauma, domestic violence, not only because what we're really talking about is recovering from some real difficult experiences that have impacted your behavior, your thinking, therefore your capacity around parenting. And that whatever those experiences are, you've kind of been taken away, or the clients have kind of been taken away from nurturing. And it's almost like relearning, or maybe they never got it, and actually being able to get those pieces. So I think that's what's so important, that it is flexible, and Terry mentioned it earlier in terms that it can be adapted. Some of the examples in some of the places that has been adapted is that it's used in outpatient services. It's not necessarily only used in residential. We've used it in homeless shelters. We've also used it in prisons, because it just is that flexible. People just really do need to learn how to nurture themselves. They think they know what that is, but often they really don't. The other thing that is clearly extremely important is that each of the topics and each of the segments really kind of promotes this kind of psychological, emotional experience that is non-threatening and based on client direction of where they're at within the group. So therefore, you may start off at one level of talking about, say for instance, growth and development, and you talk about the different stages of Erickson. We don't only leave it at that point. The reason why we even begin to talk about it is first to help the parents, the clients, understand what their childhood experiences may be putting them at risk or put them at risk, or even the positive ones. Having them to understand what happened to them, where they're at with that, what they need to gain and what they already have, and how do you build on that. So the child development, Erickson stuff, usually is used to kind of explain to parents where their child is at, given what stages of development they're at. But we first begin to do that with their own selves, with their own childhood. And that seems to make a major, major difference, especially for people who are in early recovery, who haven't really been connecting any of that kind of emotional stuff. They just know they feel inadequate, but they're not real clear where that began. They think it began when they started using drugs, but it might be the other way around. They started using drugs because early on their self-esteem wasn't built the way it needed to be built. So we kind of use those opportunities at any given point to be able to expand on what might be going on with the client. Could you go to the next slide, please? So the whole idea really is to provide a safe forum. So it's kind of, it's important that the clients, the parents that are coming into the nurturing program, that they also have some other kind of support. You want to think about that, whether they're getting counseling, whether they're in treatment, but they're getting something else, because the bottom line is that these programs, our groups, really are going to be a foundation to build on other things. So it's kind of important, and to build this kind of safe environment. Buy-in is important because clients need to feel safe about being able to implement some of the practices that we're actually going to be giving them in the training as well. Also, what happens is that there's these messages about that someone should just automatically know how to parent. And so often the feelings of feeling inadequate about parenting are kind of kept secret, only because we're talking about a population that's become accustomed to keeping secrets. And so it's really important to normalize the kind of feelings that one gets about not feeling like they know how to parent, which is all of us. Anyone that's a parent understands that. I don't care how many kids you've raised, each one challenges your sense of inadequacy on whether on how well you parent, coupled with just the whole issues of being in early recovery. So helping them to break those pieces out really, truly makes a difference.
And I'll just add one point about that. I think that this point of, everyone has some difficulty in parenting, it points to that many parenting struggles are universal. So that ends up building commonality and reducing stigma for our participants. Oftentimes, facilitators are also parents. And so there's definitely a connection in that way. These are universal struggles. So it's not an us as expert and them as, students. It's really much more of a shared experience.
Yeah, I think it's really important that there is a major focus on understanding just all of what happens based on parental substance use and kind of the residue when you come into recovery around just really being able to handle anything beyond your own personal development. But what really is of value within this particular curriculum is that we spend a lot of time helping people break these feelings up into areas that they can begin to understand, and also help them to work out some skills to actually be able to address it. And the first is just being able to identify the feeling of guilt, the feeling of shame, and how that might trigger some other stuff, and so you're not able to. Often, I'll just quickly mention an example, is often our mothers work with their children, and they've got an infant, and this infant has every little shoe that's Gucci Lucci. They have an outfit for like every half an hour, and their whole focus is really on trying to make themselves feel more comfortable as a parent. And so often what happens is that we have to help them to break that out so they're not overcompensating for their shame and their guilt. Something simple like the child crying can trigger so many things, and the child may only be crying for, maybe a minute, and we actually have to support the parent around time it, so it doesn't feel like it's been a half an hour and it's really only been, a couple of minutes, and so it's really okay. You don't have to just panic. Just helping them, because every experience feels so intense when you're in early recovery. Can we move on to the next? So some of the implementation challenges that we have supported programs around is it depends what kind of program. Some, it's not so much an issue of retention or recruitment, because often we're working with residential programs where there already is a captured audience. So that's not necessarily always an issue. But since we have expanded it over the last 5 or 6 years to programs that are dealing with parents that are outpatient, some of the issues that usually do come up is child care, what is the best time to do the group, consistency, them being able to get there on a regular basis or even get there. There's never been an issue as of yet that I know where people, once they've gone to a couple of groups, don't really be able to follow through, that they are interested in following through. They're first threatened by the whole idea of parenting and maybe be assuming that you're suggesting that they're already inadequate. So it's really about developing this and coming from the approach of healthier relationships. One, first with yourself. Then you'll be able to have better relationships with your children, with your family, with your spouses. And it's kind of like where we come from with this so that they can really begin to understand what's happening. Sometimes, often, what begins to happen is you have to think about the scheduling the group. Sometimes you just plan to do the orientation, and then it becomes a little more client-directed around the times that the groups will be. The average group really may not always be 90 minutes, but the sessions are so flexible that you're able to kind of like pull out what makes sense for you within that session, given the knowledge level or experience that you think your participants may need. So often, if you're dealing with outpatient or maybe shelters, because we've worked with domestic violence or domestic partner programs, that often what will happen is that we will begin the groups, and instead of just saying substance use, we will just talk about recovering from some real difficult experiences. Usually by the time we're like 4th or 5th session, then they become a little more flexible and then begin to self-identify often what happens. And then the other piece is really around facilitators becoming comfortable in the groups, and that happens. Our specific kind of training in how we actually do this is there is co-facilitation piece that happens. And there is a pre-meeting before the group, and there is a post-meeting for the group. And normally what happens is we will discuss what will happen within each group, what pieces they feel comfortable with taking on, what pieces they don't feel like they're quite ready to do. And as they continue to stay a part of that co-facilitation, because that's the program staff that's doing this, they will begin to take on more and more. So by the time you're at the 12th session, 15th session, the facilitator is really doing the program, and myself or my staff person are actually just really supporting them around that kind of co-facilitation piece. But it really is about supporting the staff and being comfortable with that model. So also in addressing the skills.
The next slide.
Oh yeah, I'm sorry. Go to the next slide. I forgot I got to tell somebody. Okay. So also what begins to happen is that people wonder, well, what kind of skills do you need to have in order to do this group? Well, you should have some understanding, certainly, of substance use, no doubt. And a little bit of knowledge about child development would also really help, and having had experience doing groups before. The rest of it can really be taught and supported over a period of time. And so it's really not that, it's not that mandated that you need to have a counseling degree. or anything on that order, really. It's just really about your commitment and having some sort of knowledge. Is this the next slide? The next slide, please. So I'm going to talk a little bit about the adaptations to the nurturing program. And so basically what begins to happen is besides just the parent-child kind of interacting things that we already had, we've kind of looked at some other models that make sense to kind of incorporate in there. And so part of it is this whole idea of being able to self-observe with your interaction with your child, and actually being able to kind of like self-identify or identify what is going on with your child. Often this work is important to do because people who have been actively using drugs for a very long time will be very self-centered. So it will be very difficult for them to be child-centered without really getting some information and some support to be able to consider what is going on with the child. It's very interesting that sometimes you'll hear parents say, child is an infant, maybe 2 months, 3 months old, and they're saying, she is doing this deliberately. Every time I go to sit down after I fed her and changed her diaper and just need to sit down and get some rest, she starts screaming and hollering. I know that she's doing that deliberately. And so the real idea is to kind of help them to pull away from that kind of self-centered perspective and get them to understand that children just do that, and it really has nothing to do with you or her trying to get after you.
And so part of, this is Terry, in the third edition, how we've been able to address those issues is through incorporating child-parent psychotherapy concepts, reflective functioning, and some of the learning we've had through other projects here that use CPP that really helps parents to see from the perspective of their child, which is really part of the third edition. And Diana's going to talk a little bit more about the other specific changes in the third edition in terms of an adaptation.
Okay, can I just go back to addressing facilitation skills? Because I think that this is often a major concern in terms of how you measure that. And Terry, are you going to talk about that later on, about how one measures that? Oh, Fidelity.
We do. We will, yeah.
Okay. So the only thing I really want to say about this is that that is an ongoing piece in terms of supporting staff around being able to really implement this with an emotional commitment. We found that you can check, like I said earlier, you can check off, and a facilitator can do everything that one expects or that is assigned in the curriculum, but for some reason it still seems like it doesn't feel like it's made that kind of connection with their participants, and often it has to do with the facilitator needing additional support around actually really being involved in that. The only other thing I would say that one of the things that we also have learned is that you don't want to be too heavy-sided in terms of other experiences or interaction that these clients have with the staff that are co-facilitating. You want to think about that. Are these counselors, is this their, clinical person anyway? You want to be able to think about that and how to be able to follow up on that.
Right. Sometimes we've found that people who are co-facilitating obviously have different roles in the program. So if your role is more about, making sure rules are followed, or if, part of your role is following up and setting limits or taking away privileges, it can be hard to slip back and forth into co-facilitating the groups. So we should probably move ahead then to 2 slides around adaptations for parents and children interactions. And on this slide, Diana's going to talk about the Well Child curriculum, but I just want to say one of the things that we did, because we've heard a lot of people really interested in, for good reason, worked with children as well, because this curriculum was really developed for parents, unlike Bavilec's nurturing parent programs that have side-by-side children's groups, this historically hasn't, although in certain instances we have been able to include children. And Building Family Recovery was a project years ago that I worked on here, where we created with another organization a children's curriculum to use as a companion that sort of had, based on age of kids, similar session topics. And so the kids were working on that topic while the parents worked on the topic in their group, and then they came together for an activity. The Well Child curriculum is something that is almost finished and ready for publication that Diana's going to talk about in a minute, and that is another opportunity to work with kids as well as with the parents doing this parent group. So we're going to stop here. In the next slide is another polling question. Again, to just keep everybody awake and get your thoughts on some of these really tough issues that do impact the kind of impact you can have doing groups, being aware of people's thoughts on these topics. So parents in residential treatment have better outcomes when their children are with them.
Terry and Diana, if you can see the results. About 70% of folks agree. That's split between 20% strongly agreeing and 50% agreeing. About 23% respond that they don't know, and about 6% are in the disagree or strongly disagree category.
Okay, thank you. It's Diana back. Just want to quickly just run over some of the major points of the Well Child curriculum. Actually, what begins to happen with this is that children actually need the opportunity to be able to express themselves and learn exactly what they're feeling and what's going on. And so the Well Child curriculum in the groups are really designed to help them to do that. And so if you go to the next slide, actually, that's not the next slide. That's not what I have. The Well Child actually begins to talk and focus on really helping the children to also recover from, from whatever trauma they may have been experienced. It does promote resiliency. It helps them to learn how to break the secret of abuse in the family, and just brings up and gives them a safe forum to be able to talk about what might actually be going on with them in a safe environment. It's not as long as the curriculum for the parents, but if you go to the next slide, you'll get some idea of what the sessions are, what we look at within those slides, and each of them, kind of very much like the nurturing program, has a set of objectives, certainly lots of activities that really help them to do that, and actually just helps them to work through some of what's going on. The Well Child curriculum is also pretty adaptable, because what it will do is that there are certain activities that are offered based on the age of the children that may be involved in the curriculum. So these are all the topics, but there are alternative activities that are much more age appropriate, given whatever whatever person the children would be coming into the group.
And if people are interested in the Well Child curriculum, we are happy to give you guys more information. Mm-hmm. We obviously can't spend a ton of time on it now. We just wanted to sort of let you know it's out there, and it's going to be available very soon for folks.
Mm-hmm. Next slide. Well, we've kind of already talked about most of this stuff in terms of the third edition. The one thing that we haven't really talked about was the guide for individual use. And so in that, there is a small pamphlet, kind of a guide, where you can actually take the curriculum and use it to work with individual families, maybe in individual sessions, either in residential or outpatient. If a parent needs maybe to have a little more support than what the group has offered, then you would be able to take this guide and actually pull the information from the curriculum and be able to make it much more intense and address more specific whatever might be going on with the parent.
And one of the ways we found it useful is because people either aren't ready for any number of reasons to sit in a group setting, or they may have missed a group or two. People may join late, and we want to kind of catch them up with some of the topics. So the individual guide can be used in a number of different ways.
Okay.
The next slide is about being a father sessions, which you have talked some about.
Yes, I have. The only thing that I would just like to add about this is that, like I said, there are specific issues that men need to deal with and work through, be it substance users or not, and that's kind of what these three sessions do. We offer the 3 sessions either as alternatives, and we identify where those alternatives might fit, or you could just add them on, because often they still do need to have some of that other information that may be coming from the scheduled routines. So so those are the 3 sessions. Could you move on? And I just talked about the individual guide. Terry, you want to say anything more about that particular piece?
No, I think if you can go to the next slide, Mariana, we can see if there's any questions that have come up. I know we've done a lot of talking, so we'd love to hear if there have been questions from anybody in the audience.
Great, thank you. We do have one question. The first question is, what age group participates in the Well Child program?
No, you can do that.
The curriculum was originally designed for 5 to 10-year-olds.
Mm-hmm.
We expanded it to go more like 4 to 12-year-olds.
Exactly.
And then within that large range, we have specific sessions, it's divided up into like 4 to 6 or 7-year-olds, and then 7 or 8 to 10-year-olds, and then 10 to 12-year-olds. So there are different activities in each session broken by age, because that's a very large age range, as you know. So, but the general range is from about 4 to 12.
Okay, great, thank you. One more other question as a follow-up to your discussion about facilitating and co-facilitating. You spoke about co-facilitation. Could you talk a little bit more about who those roles are, or who it is that co-facilitates the group? You mentioned one might be treatment staff, and is the other a trainer, a supervisor? Could you talk a little bit more about that?
Yes, they usually are a trainer, or there's someone that has more experience in doing the actual co-facilitating. So one way, or a couple of things that we do is that we go out to the different programs, and we actually work with the staff and just actually do the whole 17 group cycle with them. Another way is that we offer annual trainings twice a year for people to come and learn how to actually do or implement it. The other thing is that I have definitely gone out, and Terry have definitely gone across the country to other social agencies and just trained a wealth of staff to be able to do it. I've gone to Atlanta and did all of their substance abuse and maternal and child staff, and then they went out to the different agencies throughout the state, and they co-facilitated either with the clinical person, social worker, or what Atlanta did is they took their perinatal programs and their substance abuse programs, and they coupled those two together. And so they went out, after they were trained by me in the 2-day training, they went out to different agencies and started training other coupled off like that.
And I think in general it really depends on the program. As Diana mentioned earlier, there's not a requirement around educational level or particular background. We hope people have a commitment to parenting, have an understanding of substance use and child development, and really want to be there and have an interest in the groups. But in different programs, that could be the child care staff, that can be, treatment staff, if it's a treatment program, milieu staff. It really varies from program to program. But when we're training folks around the country, you know, our hope is that it's people that have an interest and ideally are planning to stay there for a little while, you know, because it's a lot of working with each other, and then when there's turnover, the hope would be that someone is always trained in the curriculum and so can then work with the next person. So I hope that answers the question.
Yes, thank you. And we have one more question for this portion of the webinar. Are there built-in times for the facilitator to observe parent-child interaction?
There aren't built-in times through the curriculum. Different programs, again, do it differently. So there are programs that build that time in and have parent-child interaction time, but it is not part of this curriculum that there's a parent-child together time.
You know, but often what we'll do, and we meaning the people, the staff at IHR that are going out and actually working with the program, what we will do is that if the clinical person is not the one that's in the actual groups, we will meet with them to just update them on what's going on with the children and the parent at that particular point, or what we have focused on with the parent and what we think is where they need to be right now in terms of application of what we've shared in terms of information. Often the clinical person might be one of the staff that'll come in and do the and be a part of the actual training. Okay.
Cool. That's it for now. We'll have more time for questions as the webinar continues if you'd like to move into the Fidelity section, Terry and Diana.
Okay, sure. Thank you. So this is Terry. I'm going to talk, you can go to the next slide, about some ways that we've monitored Fidelity. There's a form attached to this slide that I think is probably a little bit difficult to see for some of you, but we wanted to give an example, and these handouts are available to all of you, of one of the ways that you can monitor Fidelity that we've used in the past, where each session you rate, or an observer, a supervisor, rates different components of the session. So in Massachusetts, as Diana mentioned, what we do is we tend to meet before, when we're co-facilitating the parenting staff here with a program, we meet before and after the group to talk about, you know, preparation for the group before, what might come up, the content for the day, who's going to do which section, and then after to really go over and reflect on how the group went. If using a Fidelity form, which can be really helpful, you can reflect on the ratings. Co-facilitators, with or without IHR staff involved, can be really helpful for each other to give each other feedback, and we encourage that about, you know, what went well, where we might have lost people, what seemed to really resonate with people. So that's how some of the ways we've used the Fidelity form here. In terms of challenges, there are a number of those. One of them is when we adapt the program, we encourage adapting the program to meet your specific needs, adapting the nurturing program. So obviously that can sometimes be a challenge to Fidelity that we have to stay aware of. I alluded to staff turnover and training issues. That's a big challenge for programs. You know, we will work with the program, they'll get the training. I'm sure people are familiar with this. Be our star facilitator and then leave the program, and we're sort of back to square one again. So staff turnover and retraining staff can be a big challenge. Client turnover or clients missing sessions throughout can also be a challenge to Fidelity because obviously they're not getting the full dose of the program. And then I think one of the biggest is really having funds to be able to evaluate the program, doing follow-up surveys. We have not had the opportunity to really follow people post-nurturing program except for just at the very end. We haven't been able to, you know, check in 6 months or 3 months later to see if what we talked about has really stuck, so to speak. So money for evaluation is certainly a challenge and a barrier. And I think that the lack of good parenting measures is another one. We haven't come across good tools to really help measure what it is that we're trying to measure in terms of parenting and what folks are learning in the groups. If you go to the next slide, here's another example where this is for the whole session, so it's not just 1 week. The last slide was just for one session. This is the whole series. So you can use this kind of an instrument. Again, you have copies of this, so don't worry if you can't see it, where you measure each of these, how did the icebreaker go? Was it done? Was it not done? Done a little? Done a lot? All the way down through, your engaging style, your ability to listen, and the overall performance. So lots of different things are measured each week in the program, so that's another example of a Fidelity instrument that we've used. So we can stop here. That's what I have to talk about in terms of Fidelity, and if there are other questions, we'd be happy to answer them at this point.
Yes, Terry and Diana, one of the questions that did come through from participants was, how do you address Fidelity when you're implementing the nurturing program for families in a one-on-one setting or in-home?
It's a great question.
Yes, it is.
And it's difficult. I mean, if you don't have someone there observing you, the one thing that we talk about doing is self-rating. So using that form and trying to rate yourself and using supervision to talk about, the interaction and how it went to get a sense of how well you were able to stick to Fidelity. Do you have other thoughts?
The only other thing is that we have been working with the social workers that would be going out and actually doing the individual and kind of helping them to come up with some sort of scale that measures whether this is working or not, and whether they're comfortable with what aspects and what not. And then bottom line, what ends up happening is that we come back and we talk about what happened, how did it go, what might have been the issues, what were you able to get to, what were you not able to get to, and why. So it's kind of like adding discussion to the chart that Terry just showed you, but actually looking, meeting with the individuals who are actually going to meet with the family, and actually doing a schedule and kind of figuring out what the objectives might be based on the particular sessions they're going to do. Because each one of the each one of the sessions in the curriculum have their own set of objectives and a goal. So if they choose that particular session, that one of the ways that they're going to measure is what was the outcome based on what you wanted to accomplish based on the goal or the objectives of that particular session. So they begin off by first taking those and then measuring, trying to develop some sort of measure that makes sense for them.
Does that answer the question?
Yeah, I think that's great. And one more question in this area. You made reference to, the adaptability of the curriculum. Is there a specific or perhaps minimum number of sessions that you would recommend, or maybe some key sessions that you would recommend people include when they're delivering the program?
That's a great question, and we've talked a lot about this. I feel it's hard to give a number. I mean, how we've done it in the past was when we did the 12-session curriculum, the shortened version, I believe we had this was years ago, but I believe we had a cutoff of you have to be there for at least 7 or 8 sessions or something like that for the 12. But it's really, depending on what the needs of the program are, I would recommend someone talking to us directly about what sessions, I would hate to say this is a required or that is not a required session. We certainly have thoughts about what we think are key sessions that we wouldn't want people to cut. But it depends on the needs of the program, and then based on what they come up with, then we can work with them around,
what to do and how to do it.
And a minimum number of session requirements.
and that's something that we will do automatically with any program outside of treatment, because the reality is that often you're not going to get someone who's not in a program or a captured audience to really come for the whole 17 weeks. So you really begin to think about it. The other thing that we've been very creative about is actually sitting with programs and combining some of the sessions together, because they, you know, that there's a natural fit with feelings and self-esteem, for example. And what we'll do is we would develop a session pulling from both of those that would actually make sense, where you could capture both issues. Does that help?
Yes, thank you. I'd just like to point out we have about 15 minutes left, so if we want to briefly cover these last few slides so we can leave a couple of minutes for wrap-up and any final questions.
Sure, sure. If you want to move to the next slide, I mentioned the Adult Adolescent Parenting Inventory. That was a tool also developed by Stephen Bavelek that we have used a lot, and a lot of programs use to measure use pre and post to measure the effectiveness of the nurturing program. It really talks about, in the next slide I'll show you the core domains, but before that I just want to mention that we have used also a lot of participant surveys or session evaluations. We get a lot of qualitative feedback, which we'll share at the end, from participants, which is incredibly helpful, saying what's been most useful about this session, what's been least useful, what would, you know, people like to see more or less of. So participant surveys, I think, are a really great tool to use. And we have samples of those if anyone's interested for that qualitative feedback. But if you go to the next slide, I can just show you briefly the core domains that the AAPI measures. It looks at appropriate developmental expectations, empathy, whether parent has empathy for child, alternatives to corporal punishment, appropriate roles, whether the child is really in a child role or more like a parent role, and then one he calls oppressing children's power and independence, which we don't love the language there, but you know, basically it's about children having their own voice. So those are the domains that the AAPI measures. We have had some challenges with the instrument, which I'd be happy to talk about more, you know, at another time. But it is useful in really just measuring attitudes and beliefs around parenting practices.
And we do a pre and post.
Yeah. Right, and we do a pre and post. So the next slide is an example of a session evaluation that you can use with a parent, which I mentioned. I forgot that it was in here. And this, again, in much more readable print, is available to you all. And this is an example of kind of what we might ask participants after each group. So you can make it much shorter than this. This is kind of a long one. But, you know, did you learn anything new? Have you changed any of your behaviors as a result of this group? That sort of thing. So that's an example for you to use.
And we do this at halfway through the session, and then we do it at the end again.
Mm-hmm. And then next is some resources. These are just some of the articles, actually 3 articles that have been published related to the nurturing program, any of which I can get you copies of if anybody's interested. Again, as I mentioned, resource issues, we haven't been able to do the kind of study that you know, where we have a control group, where we have a sample that gets the curriculum and a sample that doesn't. We haven't been able to do a lot of post-discharge follow-up. So there's a limitation to the resources and the studies we've been able to do. But these are the articles. And then finally, just some of the qualitative feedback. I love to share this with people because these are what some of our many, many participants have said over the years to us. I won't read them all, but I'll just give you a couple of examples. Most of what I learned had to do with ways I thought I should parent, and that there really is no rule book or manual to being a good parent. I also spent time learning about my child's boundaries. Lots of great feedback. You can read through these yourself. If you go to the next slide, I like this first one. How to have fun. I learned how to have fun as a clean and sober person, how to recognize certain feelings and situations and how I can deal with them, how to interact with other people, and how to nurture myself, my family, and friends, and feel comfortable with it. The other quote that I love is, I love them all, but I'll read the third one. What nurturing is, how to nurture and care for myself as well as others, that I am truly worthwhile human being who deserves safety, respect, and happiness. So that is what we have. We can move on to questions and discussion in the remaining 10 minutes, Mariana.
Okay, great, thank you. And we'd also like to remind everybody, if we're not able to address your question during the webinar, we will be able to have some additional follow-up with Terry and Diana to have them answer it, and we will post those by next week with the additional materials, which will be available on CPM for RPG grantees and also generally for everyone on the CFF website, okay? So just a couple questions in the minutes that we have left. One of the questions is, how do you sequence in or perhaps phase in nurturing parents in treatment programs? When do you start including people in groups? Is it very early on in treatment, or what have you found to be successful?
I think this, again, varies by program a lot. Some programs have a requirement that people who enter the program have to participate in the groups, which wouldn't be our choice to have people joining in the group, but groups can be mandated in programs, and so we work with that as best we can. So in some programs, we really work with the program and their requirements. We don't have a requirement of a certain amount of clean time or recovery time. We welcome people in very early in recovery, as well as people who have substantial recovery time, and often that can work well together. But do you want to comment on that?
I think that also when I went to programs like the working with the homeless population, we've worked with people who are still active, who are struggling to actually get some consistency, sobriety. We'll work with clients like that as well, but keeping that in mind, we will tailor each of the topics with the struggle of trying to get some recovery and what that would be like. So the hope is that you would get clean, and what do you think you need to be able to do that, and just kind of like really focusing in on those pieces. If the majority of the people in the room were not owning that they were still struggling with their sobriety, but you would easily do that. If you have if you have the support of a counselor or the program in understanding that piece, then you can adapt it however you need to.
Mm-hmm. Yeah. Part of what works well in the residential programs, when people join in with folks that have been in the groups for a while, is that the support that they build with each other, the peer support is incredible. And so the more kind of experienced members of the group in terms of being part of the group, but also having maybe more recovery time, can really be positive influences, as everyone knows, on the newer folks to the group. So it has worked out quite well in some circumstances, but it really is very program specific.
Thanks. I'm going to try and squeeze in one more quick question before we give it over to Ken here for final comments, and that is the AAPI limited to a specific age range of kids?
No, it's not. It's not about specific, developmental issues. It's really focused on parenting attitudes and beliefs. So the questions have to do with, as a parent, do you think this or that particular way of being with your children is good or bad, strongly agree to strongly disagree. So it's not age specific to the kids.
Thank you. Ken, over to you.
Thanks, Mariana, and thanks, Terry and Diana, for sharing your experiences and kind of bringing to life the realities and the challenges and the successes and hope by implementing this curriculum. I thought your comments were interesting about the different settings in which you implement it, or able to implement it in the modification, so that you can implement this for folks who are either in very early recovery or not in treatment at all, as well as within a treatment program. And I think sometimes we lose sight of the fact that this. I think perhaps maybe you want to comment. This could be a reinforcer, or certainly it is a reinforcer, but even maybe it could be a way that a parent assesses how their own substance use or abuse is affecting their ability to parent. It can be motivating, I guess, is a better way to frame it, for furthering their commitment to recovery or assessing whether they need to get into treatment as a result of participating in this program. Any comment on that?
I would agree. I mean, we know that children are parents' strongest motivator to get and stay in treatment. And so this group brings to light a lot of those issues that parents are struggling with in a really non-judgmental way and supportive way. So yeah, it can really support and build on parents' innate desire to parent their kids.
Exactly, and that's been the experience that we have actually been exposed to, based working with some of the recovery connections, which are actually kind of like drop-in centers. We've actually done the parenting groups there, and they actually have motivated parents in lots of different ways. One, to either seek some other kind of support, additional support, and seeking recovery. So you are correct.
Well, thanks for that. You know, and as a person that in the past has a treatment program, a treatment background, and then I fast forward to the work that we're doing in the National Center, and we come to recognize, and you mentioned earlier, Diana and Terry, about family-centered treatment and family-centered approaches, of which this is really embedded in that context, and the importance of that. And you mentioned addiction as a family disease, and for too long, our addiction treatment, even for a long time, we recognized it as a family disease, but for too long, our addiction treatment didn't offer enough family services, and so we have an opportunity as parents enter treatment, or as we have access to parents, whether it's in early treatment or whether it's in other settings, as you have spoken about, that we have an opportunity to engage those parents, those caregivers, in a way to look at their parenting capacity, to engage them to strengthen their relationship with their children, to strengthen their parent capacity. We have access to parents, through treatment settings, and almost, I think, an obligation and responsibility to provide this kind of service that deals directly with their ability to parent. We all have challenges in parenting, and it can, as you've talked about, it can be reinforcing to the recovery, and it can also be a challenge to recovery. It can also be a trigger if we don't address a parent's confidence, a parent's feelings toward their own parenting capacity, and reinforce their ability to do it and give them the skill sets to do it. So it really is very compatible with treatment and recovery. And as I just said, I think it's almost obligatory for us as we provide treatment to parents to be able to provide this type of intervention, of parent-child intervention, of strengthening parenting capacity, because just because we become parents doesn't mean we know how to parent, and just because we may get in recovery doesn't necessarily mean we know how to parent. And having skills and strategies that deal directly with our capacity to parent and it builds our relationships with children, I think is now a critical component of both individual parent recovery as well as family well-being. So we appreciate your insights, your sharing your experiences, your knowledge with us today. I want to thank Elaine for joining us as well today. I want to thank Mariana and Jonathan in Children and Family Futures Home Office for all of your preparation work in putting this together. And I want to thank all of you participants and all 49 of you who have been with us for this session, for your time today. Please feel free to access us through the National Center. If we can provide any more information, and you see the contact information for the Institute for Health and Recovery. Between us, we will be glad to assist you with your implementation challenges or other questions you might have that may be triggered by today's webinar. With that, we hope you have a great rest of the week and enjoy the rest of the summer before school starts and vacations are over. Thank you and have a great day.